snoring is basically a noise produced from the upper airway. That's where this noise arises from. It's basically when you fall asleep, you know that your entire body relaxes. Okay, your muscles relax. Regardless of what relaxes, you should have a patent airway to breathe. But sometimes these muscles in your throat or your palate, they get a little more relaxed and start vibrating when you're breathing.
Right.
That is snoring. There is another thing more than that. If everything starts collapsing, that increases the sound and also it stops your breathing. And that's where I come into play. That's what we call OSA or obstructive sleep apnea.
Hi everyone and welcome to the Docs podcast. I have a very special guest with me today and it is none other than one of my good friends, Dr. Bimantha Perera. Bimantha and I go back a long way. And before I get into any of that, first and foremost, welcome Bimantha. Thank you for being on the show.
Thank you, Sunit, for that lovely introduction.
Right. So the introduction had to be muted or rather made concise because like I said, it's someone I met before medicine. Bimantha and I have been together in school first and then in college, in medical college. So we go back a long way. And he has that distinct pleasure of being friends with me throughout. We've been friends throughout. It's not a friend I lost along the way. So unfortunately, I haven't been able to lose him because I went out of college and went to campus and there he was. Right. So we're both from Manipal College of Medical Sciences in Nepal. And so Bimantha, there's so much I want to talk about with you. But before I get into your area of super speciality, tell us more about, I'm not going to ask you why medicine because both of us are Sokia Moda coming, Lanka campus Yanda Hinda, Sira, Sokia Moda coming Tamai, Gevala Pitarata, right? Then Gihila Mihavila Katakan. So, but why Bimantha? Why ENT?
Yeah. So the first seed was planted in Manipal in Nepal, where we had a very long ENT appointment, which actually gave the first spark. So surgery was my passion. I always wanted to, do surgery because I'm a person who really cannot memorize things. So
true.
In medicine you have to memorize. So you can't memorize. I'm very bad.
And just to add a second there, I mean, you're absolutely right. We had an entire year of ENT. It was an entire MBBS. Entire year. Whereas when I lecture the undergraduates, it's just 2 weeks.
Just 2 weeks. Right? So we really saw what the potential of ENT is. And so that was my first spark. Then obviously I was here. And then I happened to work at Sirimau Bandaranaike Children's Hospital.
Right.
Where we shared the ward with the pediatric surgical ward. I was in SHO at that time. I shared the ward with the ENT surgeon. And that's when I got through my exam. My MD Part 1 exam.
Yes.
And then one day, the consultant ENT surgeon, I don't mind telling the name, Dr. Atul Gama.
Yes, Dr. Atul, yes.
Called me to a side and said, now, what do you want to do? And I said, I'm thinking of pediatric surgery or ENT surgery because I've seen you doing cochlear implants. I've seen you doing so many fancy things. That looks good. And he said, do you have a fine set of hands? I said, yes, I have the fine set of hand skills. He said, why don't you do ENT? And then he gave me the pros and cons of everything. And then he actually showed us the potential of ENT. And that's what I realize now. ENT is not only Kangharima.
Absolutely.
Not only Kangharima. Okay. Right? So we, and not only tonsils, but we have so much of other things. We have a very fine super speciality. We can do so many minimal invasive surgeries, high tech surgeries, and give very good outcomes to patients and improve their quality of life. So the problem in ENT is 60% of all your problems, medical problems, are ENT related. Though we are very, not so spoken of.
Yeah, true. As a GP, I second that thoroughly, man. That's absolutely true.
Because you need to know how to treat a Kasana, Embrisa, and Ugre Amaru. Okay. So that's where everyone comes to ENT, but we have much more than that.
Absolutely. So I'm glad your boss and mentor recognize the fact that you have fine set of hand skills and not because you're a Thomian. So yeah.
Yes. I don't
so after school. I know what you're thinking, but no. But I wouldn't be wrong if I said now Bimantha has taken his area of interest into such a interesting topic, or such a vast, such a relevant and important area of ENT. I would call him Geravillata Adipati Deyu, because he is now, he's focused his skills on obstructive sleep apnea, or in simpler terms, snoring, right? So, Bimantha, I would love to delve more into this, because so much of us have this problem. I mean, you would be hard pressed to find a home or find a family where someone doesn't snore. So, let's talk more about this, Bimantha. Actually, let's start with what's happening here. What is snoring? Why do people snore?
So, snoring is basically a noise produced from the upper airway. That's where this noise arises from. It's basically when you fall asleep, you know that your entire body relaxes. Okay, the muscles relax. Regardless of what relaxes, you should have a patent airway to breathe. But sometimes these muscles in your throat or your palate, they get a little more relaxed and start vibrating when you're breathing.
Right.
That is snoring.
Right.
Okay. However, there is another thing more than that. If everything starts collapsing, that increases the sound, and also it stops your breathing. And that's where I come into play. That's what we call OSA, or obstructive sleep apnea.
Right.
Okay. So, interesting. When I came to ENT, I didn't know a thing I didn't know that there was anything you can do for snoring also.
Right.
Okay, but I have to give credit to my teacher, Dr. Chandra Jayasuriya, who insisted that I learn this. Okay, she pestered me, she made me go abroad, learn the skills, and come back and practice. So, which was, I have to thank her for that.
And we all know how persistent Dr. Jayasuriya can be.
She can be.
She once gave me a lecture about an hour on why I didn't choose ENT as my MD, and I had to very gently tell her, no, ma'am, I want to be a GP. I'm telling you. Yes, I'm glad she did.
And she started this and told me to get interested in this, because she said you need to help the people who are snoring, because otherwise they don't get a good deal in this country.
Right.
Okay. Not only in this country, entire world, they don't get a good deal. So, because it's more of a problem of the spouse.
Absolutely.
Rather than
it's not the guy who snores.
Yes, it's not the guy
wife,
who snores.
Girlfriend,
yes.
or whoever.
Yes.
That is trouble. Exactly.
Because the next door people also can hear you snoring. It is a problem. I have got patients where the next door neighbor had brought the patients to me and telling, sir, do something. So, yes.
True. Right. So you went through some interesting points there. So let's break this up a little, right? And let's dissect this further. What are the causes of snoring?
Okay. As I told you, it's usually the throat and the nose that's involved in snoring, right? So there are things that are relatively fixed, and there are things that change. Okay, so the things that are fixed are obstructions. Like if you have a cross deviated septum, if you have some nasal problem, if you have sinusitis and polyps, okay? If you have large tonsils, this is the commonest thing, right? Or if you have a small jaw, okay? Or
a small jaw, okay.
A small jaw, yes. Now, this is very common in us Sri Lankans, Chinese, South Indians. We have relatively small face.
Correct.
Okay, our facial structure is very small, so that also hampers. The next thing is the soft tissue component, which is your tongue, soft palate, uvula, and your epiglottis. So these are all taking part in it. That's what we talk for snoring, but there is something else: your weight.
Yes, the elephant in the room, literally. That was my next question to you, actually, about how body weight, because I've seen, now when I work as you know, I work as an MOENT for the government, and we see a lot of, an alarming number of obese people who come with snoring. So what's the connection here?
Yeah. So obesity, now I'll talk in little scientific terms here. Okay. So obesity was thought to be the main reason for snoring. Yes, it is, because there is fat deposition in your pharynx and your tongue. Now, this is not something that we really knew about. And that is why we always tell weight loss helps. Because the first place where the fat gets reabsorbed is also the tongue.
Really?
So
Interesting.
it helps very much in your treatment of snoring. So we'll come to that later. But we should also not forget it's not only the fat people. Okay. Now that's the definite distinction amongst the Caucasians, where they are extremely obese and they have snoring. Okay. But us Sri Lankans, Indians, and Chinese, we may not be very fat. But the problem is, as I told you, our jaws, our face is relatively small. So even a bit of fat deposition causes problems, right? Plus, there is another subset of people who snore even if they are very thin. We will have to talk about them a little later, separately.
Right. So it's very interesting to know because, like I said, a large number of people I've seen are those who come to the clinic have been obese, and we do advise them to lose weight. But the treatment of sleep apnea or snoring is also a complex bag of cats. So let's unpack these cats one by one. Yes. I was wondering. Now, I've seen a lot of people, I've seen this online, I've seen this on online stores and everything where they have this splint that you fix on the nose. And some people think simply putting that is the answer to all their problems. So what's the science behind this splint?
So before I come to that, I think shall we discuss a little how do we handle a patient when they come with snoring?
Of course.
You know why? Because what you're talking about, a splint, comes in our management. And I will tell you whether this actually works or not.
Absolutely. Okay. I would love to hear it because I heard a lot of people ask me this.
Yes.
And I wanted the answer from the man himself.
Yes. So I was used it. So I tried it. So you have to.
This is why you are glad you're not in proctology.
So anyways, now what do we do actually when a patient comes? We generally take a very detailed history. Now, this history is not only snoring, okay? Because you will figure out that, especially as you said, men do come to us quite a lot, but in Sri Lanka, females also do come, okay? But you have to ask about, do they snore a lot? Has anyone seen whether they're snoring? Do they stop breathing? Because that is the problem.
Yes.
Snoring is actually what, when patients come and ask me, Geravilla prashnayadda, I said, see, Geravilla vitarak nang, eka oyage gedara kattiyage prashnaya natha alpu gedara kattiyage prashnaya. Because they can't fall asleep, I can't help about that. Okay. But if it becomes your problem when you stop breathing at night.
Breath holding.
Yes. Because that's when you have a lack of oxygen in your body. Now just imagine, why is snoring a problem? Okay, snoring becomes a medical problem when it becomes this obstructive sleep apnea. Okay, ange oxygen adu nahama husma ganna one, right? But you're fast asleep. Then what the brain does is it immediately wakes you up. So from the deep sleep you come to the light sleep.
Correct.
Okay, so you actually don't get a good night's sleep.
Your sleep cycle is broken.
Your sleep cycle is broken. So in the morning you're tired. So these patients tell, "Mada dawal varude nidhi matai this and that." Okay. Number 2, when the oxygen is low, the heart starts pumping more blood to get the oxygenation going. Now when this happens, that leads to high blood pressure, hypertension. You heard of this also.
Yeah.
Okay. So what do? We go to the Dostar Mahathir, take a few pills and try to control. Okay, 1 pill, 2 pill, 3 pill, 4 pill. Next comes, with that stress, your cholesterol also goes up. And then with the additional stress, you see your sugars also going up. You heard all these things now. But now the root cause is snoring.
Exactly. You never think. You would never think, right?
You never think.
This is something so
the problem
complex.
is, if you have significant obstructive sleep apnea, the problem is you run the risk of getting early onset heart attacks and strokes, which are completely preventable.
Absolutely.
Okay. So that is the only take home message I want to tell. Okay. It is a dangerous condition. If you identify it and treat it, you'll be fine. Okay. So coming back to what we asked them. So we asked them, do you have high blood pressure, hypertension, all these things? Then we asked some questions whether they fall asleep. Okay, we asked, when you watch TV, do you fall asleep?
Yes.
When you talk to someone, not now, but okay, do you fall asleep? Right? When you are after lunch, if you want to have a nap, do you fall asleep?
Exactly.
When you're reading a paper, when you're with some friends, do you fall asleep? When you're in the traffic light, do you fall asleep? These are things we have various questionnaires and scores which we can say, okay, you have a high risk of these problems, right? Then we should not forget these people have a lot of, lethargy.
Correct.
And there's another side to it. Obstructive sleep apnea causes sexual dysfunction. A lot of people don't come out and tell.
Yes, absolutely, yes.
Okay, so these are things we do ask. Then we obviously have to examine these patients. There are certain things we do. We check for their nose, the throat, the tonsils, the neck circumference. I just asked their shirt collar size.
Collar size, yeah.
Okay, that gives us a good idea. And then what I do is generally we ask for certain blood tests if required. If the GP or neurologist has not done it, for thyroid problems. Okay, make sure that they don't have any thyroid disorders, because hypothyroidism also causes obesity and obesity.
Yes.
Okay. Then what I generally recommend is we should know how much of a problem you have. ඇත්තට ගොරවනවද නැද්ද? එක්සැමිනර් කෙනෙක් කියන්නේ. Right? The best way is to do a sleep study.
Correct.
Okay. So ඒකෙන් මං කියන්නේ ඔයාගේ problem එක අපි දන්නවා. එතකොට ගොරවනවද නැද්ද? හරි. ගොරවනවා නම් කොච්චරක් ගොරවනවද? How many times per hour? If you are snoring, do you stop breathing? ඒ කියන්නේ obstructive episodes තියෙනවා. With that, we can quantify whether you have mild, moderate, severe, or critical obstructive.
And this is during the sleep study, right?
All in the sleep study.
Just to clarify, your sleep study is not where a doctor sleeps with you.
Yeah.
It is done professionally in a hospital where you sleep and we watch you sleep.
Yes.
That's even creepier.
Unfortunately, we don't have that luxury.
It's a technician who watches you sleep. Exactly.
Yes, it is even more creepier.
Exactly.
Okay. And the problem with the sleep studies is it's not the ideal thing, because you're wired to 101 things.
Exactly.
Okay, and they tell you to come and sleep.
Yeah,
okay, so I also tell the patients, you go and have a good meal. Don't have any coffee
or alcohol.
Or alcohol, yes, and just go and sleep in the hospital, because that tells whether you snore a lot when you're lying to the side, flat. If you're not snoring when you turn to the side,
simple things.
Right?
No?
Simple things.
Simple fix.
So
absolutely.
You don't need to do not
big
rocket
things,
science.
Yeah.
So these are the little things we see what the problem is, right? Then we can give them the treatment options. So I'll just tell you there are three main treatment options. One is if you have obstructive sleep apnea, the gold standard is CPAP therapy. That's where you
the mask, basically. Yes.
Right. That's what a mask. Okay. Now they have the little tiny ones which fit the nose. Yes. So which is better, but it's a costly affair. You have to wear it every day.
Yeah. True.
Okay. And it's
the machine also costs. It costs something
a lot.
Yeah, that's right.
So and it is then not very practical, but it works.
Yeah. Just to clarify for those of you who watch, a CPAP machine is a mask that you fix onto your face and it seals your face, right, Bimantha? Correct. Yes. And we pump air at positive pressure so that the air pressure maintains your airways open.
So basically, as I told you again, it's a question of the soft tissue collapse. Right? So what we are doing is we are splinting it by giving a pressurized air.
Yeah.
So now anyone would understand if there is a physical block, we have to correct it.
Correct.
That's where again the ENT surgeon comes into play. If you have a crooked nose, we have to correct it. If you have massive tonsils, we have to just remove it.
Them. Yeah.
Okay, and things like that. Then there is another side to it. There is a surgical aspect as well, which is something which is probably a novelty still. Okay, so there are a subset of people who can't use CPAP.
Yeah.
Okay, or who don't want to use CPAP, or for financial reasons they can't use CPAP. Then what I do is what is recommended is to see where the problem is.
Correct.
Now we know what the problem is. We know whether you have only snoring or whether you have obstructive sleep apnea. Okay, and if you have obstructive sleep apnea, we give you a CPAP. Okay, but if you want to know where the problem is, especially for those snorers,
correct,
and for people who can't wear a CPAP mask, we do something called a drug-induced sleep endoscopy. DICE.
Yes.
හරිද? අපි මොකද්ද කරන්නේ?
We drug you.
We drug you, basically. Okay, don't worry. We don't ask any personal information. Okay, but you probably might reveal. I got very nice people telling me, no. There's one person, I'm not going to mention names, but he, when we gave him the medication, he said, Amsterdam is so nice. I was like, there are people around here. Amsterdam is very nice. We didn't want to hear anything more than that. Anyways, so it's like that. We just give you some propofol. That's what we use in Sri Lanka. We don't have other medications, but we use propofol, very calculated by an anesthetist who does this very often. And we just put you to sleep. And when you start snoring, we put the camera in and see.
Correct, yeah.
Where the problem is. Because if it's the soft palate, if it's the your tongue base, if it's your tonsils, there are things we can do. And very rarely your epiglottis, that's apidishvikava.
Yes.
If that is collapsing, surgery is probably the only best option. CPAP is not a good option.
Right.
Okay. So now there are so many techniques. We practice over 15 to 20 different techniques. Not only the ENT surgeon, sometimes we even get the OMF surgeon involved. If they have, tiny jaws and things, we can bring their jaw forward, and they do perfectly. Okay?
Yeah.
So you can get good results, but I have to say, surgery is never 100%.
Correct.
Okay?
Yes.
CPAP does give 100% or 0%. It's not a 90%.
One or the other. Yeah.
Yes. But surgery is never 100%, but you do it only once. Okay? But if we can at least cut your obstruction, I couldn't care who's about snoring too much. As long as I save your life and prevent you from going to
oxygenate your brain, basically.
Oxygenate your brain and prevent you from getting a heart attack, that's good enough.
Correct. Yeah.
Okay. So I think that is what internationally also they try to achieve.
Yeah.
But in the meantime, snoring also can be reduced significantly. So now with the thin people, that's where the problem is, because it's very difficult to, catch this group. They can be young, very lean females, predominantly females, who come with snoring. So we call this upper air resistance syndrome.
Okay, this is the first time I'm actually hearing of this.
So again, the tonsils and the palate is where
the problem is.
Are a problem, and surgery does help.
Right.
Okay, surgery definitely does help with this. But these are slightly painful stuff. Okay, but we have minimally invasive procedures as well. The next is, so I told you two things: either surgery or either CPAP. The third is the most important thing. Okay, is lifestyle change.
The most difficult one as well sometimes. Yeah.
අපිටත් ඒක බෑ.
ඒකනේ ප්‍රශ්නේ.
ඒක බෑ.
ඒකනේ කොණ්ඩේ යන්නේ.
කිව්වට බෑ. Yeah. But what do you call? Diet is important, but people think that diet alone will let you lose weight. It doesn't. Okay, at least this is my personal experience.
No, you're absolutely right. It's a number of things.
Yes, it doesn't. But walking is very good. And we really encourage them to do the dynamic exercises more than the static exercises.
Absolutely.
Okay, so that's basically walking and running rather than the weights. Okay. So that is a very, very important thing. And actually, so my teacher, Dr. Chandra Jayasuri, used to always tell the patients, if you tell them to fast and diet, it will never work. Okay. So you literally divide your plate and let them eat. Okay, let them eat, but reduce the quantity little by little, which is a very practical thing.
Yeah.
Okay, so it's like Kosal Rajuro. එක දවසෙන් ටික අඩු කරනවා. So actually now we also can't eat a lot. No, those days අපි college යන කාලේ අර අපි බුරියානි එහෙම කන්නේ ඉස්සර. Just like that. So those days we can whack 2 buryanis without any problem. Right? But now can't.
Exactly.
Now can't. Because we can reduce that amount and we can get a good satiety with it. The whole trouble is the size of your stomach.
Correct.
Okay. So now
which changes, mind you. This is what people should need to understand. If you reduce your quantity, your stomach will adjust.
And that is where people with snoring and OSA, for obese people, sometimes we don't do surgery. We actually recommend them to get bariatric surgery. Okay, because that will help them lose weight.
Which is stomach stapling.
Yes. They do several things. They are complicated stuff. I'm not going to talk. It's not my area of expertise. But that is one thing we need to look
But we've seen, ahasai polavai level changes in these patients, no?
Because don't forget, no ENT surgeon will operate on an obese patient.
Understood.
Because the results are not good. Okay, CPAP is much better, safer.
Correct.
Okay, it's safer because some of these surgeries are very big surgeries. When you have to do big surgeries, when there is an option that is much easier, I always give that option.
I'm glad you brought this up because I want everyone to understand that you as a surgeon, and I have having worked for ENT surgery for now 15 years. අපි මේ පැනලා කපන්න බලන් ඉන්නේ නැහැ. People think that අපි හරි කැමති අර දෙක උස්සගෙන ඉන්නේ මේ ඕන්ලා කපලා මොකක් හරි අයින් කරන්න. No, that's not it. Surgeons aren't always there to cut you open. We will avoid it as much as we can because the amount of trouble you get into, Bimantha, when any number of things can go wrong, no? And you're taking a risk with your life. Every surgery is a risk with your life. It completely depends on the skill of the surgeon and the skill of the anesthetist also. And there is a component up in God's hands or whoever's up there, right? There's no matter how good we are, just for your bad luck, something can go wrong. So we are not promoting you get surgery done.
Absolutely.
It will be the antithesis of that.
Absolutely.
No, we do it as a last resort. Right? I'm so glad you brought this up.
Yes. So that's it. So people do come to us telling that we want surgery. I said, yes. Have you tried the other techniques first?
We tried the easier part.
Because if you can't do that, I will offer. But I always tell, I think it is good culture that as doctors we have to give our patients the pros and cons and what realistically we can give them rather than ari api karamu. Okay, because I think these surgeries are not like cutting an appendix.
Correct. Okay? It's not black and white.
It's not black and white. The failures are there, so you may not get it. You may not get 100%. Okay, so there are a subset of people, they'll do very well, but there are a subset who may not do. Okay, and that's why I usually do this dice, because I sometimes tell the patient, see, best is CPAP for you. Okay, unless you really insist, with guarded outcome, we may be able to give. Or I would refer to another center or a place that would do it.
I guess it also comes down to the patient's expectations also. We have to manage that most importantly. Like, give you an example again from ENT. Like, when we do myringoplasties, or rather when we fix the eardrum when it's perforated, so
especially the ones who put the cotton bud then
so anyway, moving on. එක වචන පස්සේ අයින් කරන රංග හරිද ළඟදීම මිහිරි දාන TikTok එකක් මම මේ කහනම එපා කියප එක කියලා. But my point is, so when these patients come to clinic, patient asks, then doctor මේ කරාට පස්සේ මට ඇහෙන්න ගන්නවද කියලා. Then I have to always tell them අපි මේ ඇහෙන්න වැඩි කරන්නේ නෙමෙයි කරන්නේ. Sometimes you may not get your hearing. It's a bonus. It's a bonus. අපේ පරමාර්ථය පැසනක නවත්ත ගන්න එක. So that is why we do this surgery. හැමෝටම යම් තාක් දුරට ඇහෙනක වැඩි වෙනවා, but සමහරට ඇහෙන්නේ නැති වෙන්න පුළුවන්. ඇහිම ඔයා හිතන තරමට improve වෙන්න නැති වෙන්න පුළුවන්. හැබැයි බලාපොරොත්තු වෙන්න එපා ඒක. So we have to manage the expectations, because your patient steps in thinking, okay, I'll stop snoring after this. Right? You relieve the obstruction from the surgery, but they are still snoring. අන්තිමට අපිට කන්න වෙන්නේ වයිෆ් කෙන්නේ නැත්තම් පාර්ට්නර්ගෙන්. ඌ තාම ගොරවනවා මට නිදා ගන්න බෑ මොන මගුලක්ද මේ. Right? So you're absolutely right. It's about management of expectations.
But there's another side to the surgical aspect, especially people who are having high blood pressure and things. There are research that shows that now they have been able to reduce or reverse the patient's high blood pressure status. By correcting
That's interesting.
This. And there are long-term studies coming in from Singapore and India.
And I've also read that since you brought this up, it's a very, very important point. You brought how much snoring can snowball into something bigger. It's also how the disturbance of the sleep cycle affects cortisol levels, isn't it? And that leads to diabetes as well. So, I mean, all of these, again, like you said, if you're treating your pressure, if you're treating your sugar, you're not addressing the root cause.
You're not addressing the root cause.
Yeah.
So I had a good example. 2016, I'll tell you. So that was when I came to Kalubovila. I was a registrar.
Yes. We were together. We worked together for a while. I mean, I gained weight at the time because after every surgery day, Bimantha and I would disappear during lunchtime. We were on those shops in Hill Street. Cut
that part also.
I remember getting calls from the boss like, madam,
yeah, so I lost track also.
Sorry, 2016.
2016, yes, 2016. I had seen a patient, and our consultant I had seen. We had done this drug-induced sleep endoscopy, and we actually suggested this patient should have a CPAP. He was 28 years old. Okay. Now, 8 years after that, he came back to me, to my workplace, telling he has snoring. And I saw his old records with my handwriting. Okay, and I had written in that explicitly telling I have discussed the dangers of this and he should go for CPAP, or if not, at least consider surgery. 8 years after that, he's coming to me. Now he's 36. He's already suffered 2 strokes. Wow. He's 36 years. He's suffered 2 strokes. He's on 4 antihypertensive medications. Okay. And he's coming and asking, Sir, surgery ka dan karamuda. And he said, I just can't use the CPAP. He couldn't afford it. So I said, see, okay. He was obese, right? And I said, I'll have to do something because now I can't leave this guy.
Exactly.
Okay.
Yeah.
So,
but this old adage about the horse and the stable door comes to mind.
Yes.
2 strokes, good grief.
So it was not only my effort. We jointly did this surgery, and I'm happy to say now it's nearly 1 year. The cardiologist has actually reduced his blood pressure medications just to 1.
Yeah, there you go. Right, there you go.
And he's lost another 15 kilos afterwards also.
Wow.
So it's very good because අපේ පොඩි ට්‍රික් එකක් කරාට පස්සේ කන්න දෙන්නේ නැහැ. බොන්න කියනවා. බොන්න දේවල්. ඒක කොහොමද අඩු වෙනවා.
නේ හොඳයිනේ මචං ඉතින්
it works because there is a little pain anyways now after surgery, so the patient is also very careful.
කන්න අමාරුයි.
So patient is also very careful. I take that advantage and
excellent.
That is again my teacher's teaching. Take the advantage when you can. Because the patient might not come back to you to lose weight.
Exactly. I mean that there you go. That's a perfect example of of cause and effect. No, I mean we'll be treating the effect, we'll be treating the strokes, we'll be treating the pressure, but you wouldn't think that all of this had a root cause under snoring. Exactly. So Bimantha, just to wrap things up, what do you see as the future of the treatment of sleep apnea? What are the new things that we can do?
Oh, there are plenty of things. Actually, it's now it's a sub-speciality in other countries. In Sri Lanka, we have only about 50 to 60 ENT surgeons, so we can't have a sub-speciality. But in India and in Singapore, it's vastly developed.
Right.
Because this area only has this problem the most, unlike in the West.
You mean South Asia?
South Asia.
Interesting, okay.
Why? Right. We are thin, lean people who get fat very fast, but we get fat around our faces. So that's where we need more treatment, more than the Suddha.
Right.
Okay. Suddha CPAP demand dunnama hari.
I've seen a lot of the
because they're obese.
West use it,
Yes, they're obese. But we are not like that. So in our centers, surgery does help to a certain extent. So now our diagnostics have improved vastly. Our knowledge in diagnostics have improved vastly. And then the techniques, minimal invasive techniques and various novel surgical techniques which are very easy to perform, unlike those days which are very complicated stuff, right? And they get better outcomes. They've also developed certain things like something like a pacemaker now. It's there. It's already in the US, and now I think since 2 or 3 months, they are doing trials in the UK and Europe as well, where they give a pacemaker to your tongue. So when you sleep, it stimulates the tongue and keeps the tongue from falling back. Because the tongue, when it falls back, causes all the trouble.
Right, yeah. So it stimulates the tongue muscle so that it's, oh wow, that's interesting.
And now we'll come back to your nose problem. Huh?
Yes, correct.
Right. So there are two pieces. One that you put here,
inside and one you fix here. Yeah, correct. Yeah.
There are those websites, which I won't mention the names of the websites, but they tell there is either one here and one on top. So what they do is actually, if you have a nose block, you breathe, whatever the air you breathe goes in from these two nostrils. If they are collapsing, all you need to do is open it up.
Correct.
So you put a splint like this or a plaster, it opens up your airway, which works very well, because don't forget, for snoring, the problem is your airway going in. And if you get a turbulent airflow, that's where the problems come. That's why we correct the septum. That's why we correct the palate.
Correct.
Okay.
But that's just up here, isn't it?
Up here.
That's just
there are other problems
a fraction of the whole issue. Yeah.
Yes. There are other problems down there.
Absolutely.
So if you only have a nose problem, it works perfectly. But if you have other problems down, no, sorry, it's not going to work.
It's not going to work. Exactly. Absolutely.
Okay. But there is another thing. Mandibular advancement devices, just mouth guards, simple mouth guards, work perfectly if
the
your
problem
jaw
is your jaw.
falling down.
Correct. Yeah.
So actually, in the sleep study, we test that. We lift the jaw and see whether you stop snoring. If that's the case, go to the dentist, get a mouth guard made, or you can order those from the websites,
and you're done.
Exactly.
So that's more stuff that's happening while you're sleeping. The sleep study is sounding creepier by the minute. Yeah. Okay.
Yes.
There are people like holding your jaw for.
In the sleep endoscopy. Yes. Definitely. Yes. And when you get up also, you start talking a lot of things. That's the time people actually talk. I don't have anyone except my wife. Okay, fine, we believe it. Okay. So people actually tell that to us. So don't worry, we never ask personal things and everything.
We don't record.
Yes, and it's all confidential. But the patients... It's a nice exercise to do, because we show the patients what they have and then they understand. Because it's very important that the patients have to understand what their problem is.
Absolutely.
This
is the reason why this show is happening, right? Because I firmly believe Sri Lankans have that capacity, right? They are intelligent, they are so intelligent. And it's a failure on our part in communication if the patient doesn't understand this. I'm so glad you brought this up.
I don't believe it's just writing and telling. You have to, I think our generation, the new generation is coming up like this. So that is how it should be. Yeah. Because patients do expect, not like those days. Okay. They also read and come. No?
Yeah. Oh, they're on Google. And they'll tell you.
Google uncle.
Google, exactly. Google is your biggest nightmare.
සමහරට අපිත් ඒ වෙලාවේ බලනවා.
දන්නේ ඒක තමයි අපිත් බලනවනේ පොටකට.
Because they come and ask, because there was a patient who asked, do you have this device? I said, sorry, we don't, but he has seen, no, it's there in the US. Yes, you can get it fine. Absolutely. But I said, I'm not trained to do it, but we will see what we can do. It's like that. So it's an evolving thing. Snoring is an evolving subspecialty, and there's a lot we can do, but the patient has to understand the limitations, what we can help, and the patient's commitment to get it cured.
Getting it cured, yeah. Okay, absolutely.
Usually, when they are lean and thin, it's usually their wife's or girlfriend's commitment to get it cured, not them. Okay.
True, because they're not suffering otherwise.
They are not suffering. They don't even know. Yeah. That's the problem. They don't even know.
Wives, girlfriends, neighbors.
Yes, neighbors.
Yeah. This is true. So, Bimantha, actually, while talking to you, I kind of realized where your first spark for ENT was. I'm sure you've forgotten this, but I will remind you. You and I both have had our time with Professor Deepathy.
Yes.
Our anatomy teacher. She was a walking nightmare. We loved her. It was a love-hate relationship. But I mean, this was, she was the strictest human being I met in my life, and we were scared witless of her. So then, Bimantha පොඩි කාලේ උපුවර. හරිද? මු කැම්පස් එකේ ආයි කියලා වැඩක් නැහැ. උපරිමට වැඩ කරලානේ අපිත් බයවල හිටියේ. දැන් මු අයියානේ ඒ කාලේ. දැන් මුගේ ලෙවල් එකට අපි කොහොමද එන්නේ කියලා. You in the dissection hall, you went and ate it for all of us. Okay, then මූ ගිහිල්ලා dissection hall
They all
එකේ.
hated me for this.
ඒක මූ ගිහිල්ලා dissection hall එකේ වැඩ පෙන්නන්න. Then we were dissecting the head and neck, right? He took the cadaver, we cut open the skull, and this fellow spent a night in the dissection hall and the entire day dissecting the ear. හරි මේ skull එක මෙතන calvarium එක open කරලා දැන් අර කන ඇතුලෙන් ear drum එකේ මොන ossicles ඔක්කොම වැඩ ගන්න හැටි මං කියන්නේ යකෝ alien torch එකක් ගහලා torch එක අස්සෙන් අර ear drum එක ඇතුලෙන් අරව වැඩ කරන හැටිත් මූ දැන් පෙන්නන්න හදලා තියෙන්නේ. හරිද? So when we went the next day for our junior batch dissection, Madam Theodore said, look at what Bimantha has done, you know, he's such a මන් දන්නවනේ ඉතින් මන් දන්නේ නැතේ මුගියට මන් දැන් මට කට හිතාගෙන අහන් ඉන්නවා Bimanthaගේ වර්ණනාව.
had cursed me for that.
Yes හරිද? You can imagine I'm feeding here, right? Like මුට විතරද වැඩ පුළුවන් sort of thing. So I took the challenge. I was like, fine, I'll do it, right? I mean, what the hell? It's not just him, no. උට පුළුවන් නම් මට පුළුවන්. මොන මගුල දිනලා මාත් ඔක් කරා කපාගෙන දැන් තකට තක කියලා දැන් මාත් දැන් ඔළුව කපාගෙන ඔක්කොම ඩිසෙක්ට් කරා. So I did this. I did the same. I did the dissection. I did everything. I don't know that you know this, right? So when Madam Theodore came the next day I was showing her this the next day. I was already with the torch and now my ossicles are also moving and all that and this. She came in, she stuck her probe, right? And with the first probe, she broke the ossicle. She broke my dissection. I got so angry at her and you, right? It was the only time that I stormed out of the dissection hall. And Madam Theodore had called and said, Sunita, I'm so sorry.
Yes.
It was good, but I'm so sorry. I remember this like yesterday where I don't know, I was like, at least කමන්නේ මම කොහමද ඒක කරන්නේ දැනටමත් ඒක කරලා තියෙන්නේ ලංකාවේ දෙන්නෙක් විතරයි. To the best of my knowledge, nobody else was that nuts to dissect.
To go out of the way and do it in the night and
Exactly. Spending a night in the dissection hall isn't pretty because you're surrounded by dead bodies and formalin. So by that time you were quite used to it, right?
No, I remember that very well because quite ironically,
Yes.
it was one of my most memorable experience. And now as an ENT surgeon, we are conducting this for our trainees.
Yes.
Dissection course. I said,
Yeah.
bloody hell, I also used to do this, no? And but surprisingly, when you go abroad, you'll see medical students doing this. You know, and they have all these things virtually now.
Yeah,
Even,
true.
Even for OSA, they can teach you virtually. Yes,
Yeah.
it's
That's where technology has come. No, I mean it's been what 20 years since we did our degree. So
now
unfortunately,
they're actually even developing AI tools to get algorithms for snoring. I don't know whether it will come soon, but
But there you go, right? And where was AI 2 years ago? Not non-existent. And now look at how much of an advancement we've made.
AI නේ විතරයි.
ඒ කියන්නේ My goodness. And thank you, Bimantha. Thank you so much. It has been an enlightening conversation. And ගෙරවිල්ල ගැන, obstructive sleep apnea ගැන, if you also have it, ප්‍රශ්න තියෙනවා නම්, comment them below. And we will have Bimantha once again to answer all your questions, whichever questions you have. I'll answer question number 1 again, just like I did for Chamara. Yes, he's taken. Sorry, ladies. But anything else you have with regards to snoring and sleep apnea, ask away and we will answer you. Thank you, Bimantha.
Thanks a lot, Sudhit. It was a pleasure.